Good evening, everybody. My name is Nesse. I'm the CEO of the Mayo Clinic Health System, as was mentioned. Been with Mayo Clinic for 32 years and spent a lot of years in recent past working at our sites in Wisconsin. And as I bring that up because I come back here tonight, I see some faces from my time in Minnesota, and you all look older and wiser. Maybe I look the same to them, I don't know. So it's great to be back. I also want to reflect before I start my remarks that as a part of an organization that does business nationwide and actually internationally, and as you consider the situations in Florida and in Arizona right now, the expertise and the integrity of government services in Minnesota is something we should appreciate very much. So thank you to the commissioners for all that you do. And that said, however, we also have to recognize in this room that one of the challenges we all face is that our self-interests aren't always aligned perfectly with the full breadth of public interest. And so we're in for some whitewater changes going forward. What I really am going to talk about tonight are really the inevitability of change, and then I want to talk very specifically, in a very short period of time, of course, about what are the essentials of response that we all have to be viable in the future. At Mayo Clinic, in my position, and with the folks I work with, we very clearly understand that unless the health system changes significantly, we do not have a sustainable business model for the future. And my guess would be if Mayo Clinic doesn't think it has a sustainable business model for the future, you're probably thinking the same or ought to be. At the same time, the changes that have been trying to occur for many years in some ways were stymied because the other parts of the healthcare industry were more stable than we were. But that has now changed. You heard Commissioner Murray Regala talk about some of the insurance changes, and I believe President Obama called it the healthcare insurance reform activities rather than just healthcare reform. And just think about the impact if you were an insurance person going to bed and trying to figure out your sustainable business model, where you have to now insure everybody that asks for it that qualifies for insurance. You can't actually pick the healthier population. That's a guaranteed issue. The benefit set that you must offer is actually going to be set by benefit sets that exist elsewhere in the state, and you become one of 4 rankings for services offered on the exchange. And oh, by the way, the individual market, which is the toughest sales market for your business, is going to increase from 6 to about, I believe, 20 to 22% of the state, based on what we just heard. What are you going to do? Well, you could decide as an insurance company, maybe you'll just buy a bunch of providers and you'll become a huge provider group, and some are doing that. You could decide you're going to hunker down and you're going to really get tough with the doctors now, and some are doing that. But some are saying maybe there's a new model and it's time to start some new collaborative approaches to the future models of healthcare, and let's get on with it. For those in this room, for those that I talked to back at our home shop in Rochester and of course in the Midwest, what we talk about is the fact that healthcare reform is already well underway. It's been going on for a couple, 3 years now, actually. And we now see the legislation that perhaps codifies and can show us something about the future, but the change is dramatic and it's accelerating. Within the challenges that we face in the short time that I have, I want to talk about 2 things. The first is, what do we mean by pay for value? And the second is, what do we mean by accountable care? Pay for value, we can talk about triple aim, and pay for value is pretty close. We're going to be paid for our outcome, safety, and service over our costs over time. That's what value is in terms of an organizational model for your future. That implies some things, of course, in regards to measures, who measures, how do you measure, who's in charge of that, and I'll come back to that in a minute. The second thing I want to talk about is accountable care. Senator Durnberger and I were privileged to know and work with Dr. Jack Wenberg of Dartmouth and the Dartmouth Institute for many, many years prior to his retirement in past years and passing the torch to Jim Weinstein. And we also know Elliot Fisher pretty well. Accountable care is a theoretical construct. using the Dartmouth database, Elliott and his colleagues, back in I think about 6-7 years ago, 2006 or so, they published their paper. They looked at the utilization of services by zip code and then by providers. And what they found was, as we could have told them, that people use services from networks of providers that tended to concentrate around hospitals. And when they saw that pattern, they said in their paper very clearly, boy, there's a whole lot of things we've got to deal with, but it looks to us like there is a network of providers with hospital services that could maybe be accountable in the future for how we do healthcare. And it all tumbled from there. The situation right now is we have a theoretical construct for accountable care in this country. We have very few providers nationwide, with a huge concentration in this state, by the way, that are actually capable of doing it. So what are the essential elements you must have if you want to do accountable care? You have to have a network of providers, because you're going to be responsible for your costs over time and for the quality of the patients that you have responsibility for over time. Therefore, the care network has to include collaborative activities between continuity providers in the primary care area, procedural providers, and others. You have to have a network of providers. If you've got that, you have to align their purpose. You can't have one group of providers responsible for filling beds in the hospital while another group of providers are responsible for keeping people out of the hospital, right? So if you now have a network, they have an aligned purpose. You've got to coordinate the care. You have to smooth those handoffs, increase the flow, decrease duplication of work, and improve the service so that you're managing the patients rather than having them manage their care episode over time based on God knows what, usually some advice from someone else. They become the care managers in the absence of coordinated care. And when we ask people to be responsible for their outcomes, we must provide them a system within which they can be responsible. If you have that in place, you must have an aligned financial model, because you're going to get paid for your costs over time. And unless you have a financial model that's aligned to support the network of care that can distribute the money, you're not going to work. You don't have the opportunity even to do it. That aligned financial model not only is across how this provider group might get paid, but it must reward value, not volume, and it must appeal to your better angels. Or else you'll be stuck in a perverse system in which you get paid less and less for providing higher and higher value care. Well proven by Brent James over many years in Utah. The better care they did, the lower their reimbursement. We must align that system. And last, and perhaps hardest, surprisingly, is we must have practice analytics. If you don't know what's going on with patients who you're responsible for, almost on a real-time basis, you're always going to be reacting to the use of the system, not managing the use of the system. This is going to require significant new collaborations. I think you just heard it said earlier by our Commissioner of Health, this is going to require integrated groups. That does not mean you all have to be owned by somebody, but you better figure out what your network is. And that's what Dr. Mayo was talking to you about. Your network is going to be based around shared practice analytics. The rest of it can flow from that. But unless you've got that figured out, and unless you have a network of providers with aligned purpose coordinating the care, the financial model can't align, can it? So keep that in mind as you go forward thinking about your future. Those 5 things: network of providers, aligned purpose, coordinated care, and aligned financial model practice analytics. You put that in place, you're going to define the future. The last thing I'll say is, if you think about what I just talked about, where does that exist? Okay? You're chuckling, but the best place in the country right now where those elements exist is in Minnesota. Perhaps Washington State with group health at Puget Sound. and a couple of others. But the state of Minnesota and a good portion of the state of Wisconsin are where we have the elements. We have to decide if we have the will. I believe firmly that the transformation of healthcare that brings the theories of accountable care to reality is going to occur within group practice. I believe that. I believe group practice doesn't mean owned practices, it means networking groups. Group practice exists in Minnesota, and I would very much like groups like this, groups like my Minnesota Academy of Family Physicians and others to come together, take the charge. You can transform healthcare. You just have to decide we're going to do it rather than react and be victimized by others to do it for us. Thank you.